So generally speaking, and this is backed up now by advice from the MHRA, is it's reasonable to treat most, if not all, of your patients for 5 years, for example, with bisphosphonates. Then you take a step back and consider whether you're justified in continuing treatment beyond that. A couple of situations where you probably are, where a patient has multiple vertebral crush fractures. There we have reasonable evidence that you're still going to benefit the patient going beyond 5 years. And then those who have generally really low bone densities, well below T-scores of minus 2.5 at the femoral neck. So some changes in clinical practice there and some safety updates, which you can see on the MHRA website. So moving on to this new anti-resorptive, denosumab. So this is a monoclonal antibody, as its name suggests. It comes in one dose. It's a pre-filled syringe. It's a simple subcutaneous injection. So immediately, it's easier to administer than, say, an intravenous bisphosphonate. It's very rapidly acting. Within 1 day, you've got an 85 to 90% reduction in bone resorption, osteoclast-mediated bone resorption. 60 milligrams once every 6 months. Clearly, it can be given in primary care. It has 2 licensed indications. Firstly, for postmenopausal osteoporosis. Secondly, for men with CA prostate who have treatment-induced bone loss. It works through the rank ligand system. So it's an antibody against rank ligand. Rank ligand is shown here in the green. That has to interact with the rank receptor, the red thing on the surface of that pre-osteoclast, to cause formation, function, survival, activity of osteoclasts. Osteoblasts also secrete the yellow stuff, shown in yellow, OPG, osteoprotogerin. That's a decoy receptor that binds to rank ligand and stops it interacting with the rank receptor. Denosumab mimics OPG, that decoy receptor. So it's a very neat idea, and it's a very effective treatment for switching off osteoclasts. These are the fracture data from the major trial, the Freedom trial. Again, 7,000 plus patients. Very similar data to those I showed you for IV zoledronate, with 70% reduction in vertebral fractures and a 40% reduction in hip fractures. And you've got to have hip fracture reduction data to get NICE approval. And it does get NICE approval on the basis of that. In contrast to zoledronate, and I'll introduce some contrasts here, you preserve that efficacy with increasing age with respect to hip fracture reduction. These are not head-to-head data, and they are post-hoc analyses. Nevertheless, if you look on the left, that's the overall population data. On the right, for those over the age of 75. You certainly preserve it, and you see no signal for loss of effect with age, and that applies to all different types of fracture. Another difference is this, and you may think, well, goodness me, I'm definitely going to go to sleep now. He's showing me bone density data year on year. That goes up and up with denosumab, and we've now got some phase 2 data out to 8 years. So it carries on up almost in a straight line. Contrast that with zoledronate. This is 6 infusions of zoledronate annually, one infusion once per year. It goes up and then it plateaus, and that's typically what you see with all the bisphosphonates. So there's a definite difference there between the two anti-resorptives. And you say, well, does that really matter? And the answer is it probably does. And I'm showing here the correlation between increments in bone density on the horizontal axis with fracture rates on the vertical axis, vertebral on the left, non-vertebral on the right. And there is a significant correlation between the two, particularly for the denosumab data. So the bigger the rise in bone density, the lower the rate of fracture. So there are differences between denosumab and bisphosphonates. There are certainly different pharmacokinetics. As soon as a bisphosphonate molecule exits the vascular compartment, it sticks on the surface of the bone very strongly, and it doesn't move. And an osteoclast ingests the molecule, and that's how it works. Whereas denosumab is a continually circulating antibody. So there's some differences in mechanism of action, possibly some head-to-head data. Denosumab may have a better effect on cortical bone, which may be important as you get older. There's a PTH surge with each dose. Every time you give the dose, you switch off osteoclasts, lower blood calcium slightly, and then you get this PTH surge. And that might also have an effect on bone strength. And quick onset, quick offset of action, and it's not nephrotoxic. But don't get carried away, because if you have renal impairment, and it's licensed down to an eGFR of 15, but then you run a much higher risk of denosumab-induced hypocalcemia. And you've got to make sure your patient's vitamin D replete before each injection. So our policy in Wales, it's an all-Wales agreement, so we measure vitamin D before each injection together with a bone and renal profile. I've said it's quick onset, quick offset, and this is what happens to bone density. You treat for 2 years, stop it, the bone density will go back down to baseline very quickly. So the inference is you've got to carry on treating to maintain benefit, and that's a bit of a problem in some circumstances. And what we're doing is we're treating with denosumab and concentrating on patients who have more severe osteoporosis. And if their bone densities come out nicely and we're satisfied with their bone density, then we might stop the denosumab and give them a single infusion of zoledronate to try and preserve that effect. There are no fully published data to support that, and we're just gathering bone density data in the clinic as we go along. A couple of safety issues, and the MHRA have issued an update on the risk of hypocalcemia. There have been several cases of severe hypocalcemia where it's been used in situations where patients are not vitamin D replete or they've got advanced renal failure. So it's often where it's been used inappropriately. So you've got to be careful, particularly where people are at high risk of hypocalcemia or at higher risk. Make sure they're vitamin D replete. Make sure they're taking calcium and vitamin D supplements. There have been a couple of cases of atypical fractures associated with denosumab, but they're so rare at the moment, we're not sure if the association is the same as it is with bisphosphonates. It is nice, approved if you like. There's a single drug, HTA, so it does have some nice approval, so that enables us to use it. We've treated about 1,000 patients now in Cardiff. We use it second line after the other treatments, and generally speaking, it's been remarkably well tolerated. Of course, there's a cost issue. It's about £30 a month, and now that we've got generic zoledronate, that puts increased pressure on us when we're choosing between the two treatments. So moving on to the only anabolic treatment we have, which is daily subcutaneous teriparatide. This is 1 to 34 human PTH, comes in a pen, there's only one dose. You can use it for men, male osteoporosis in women, and steroid-induced osteoporosis. It's very different from anti-resortives. It stimulates, increases bone remodeling and stimulates osteoblasts more than osteoclasts. So you get new bone formation and significant reductions in vertebral fractures and non-vertebral fractures. And here's a before and after transiliac bone biopsy. And I think you can probably see that it's truly anabolic, building new bone. The emphasis I want here is for steroid-induced osteoporosis because it tackles the pathophysiology of glucocorticoid effects on bone, which is to suppress osteoblasts, and it will stimulate osteoblast function. And there are some head-to-head data with alendronate showing it's more effective. So you see significantly fewer vertebral fractures, teriparatide versus alendronate. So it's a good treatment to consider for patients on steroids. It's very expensive. It's £300 a month. It's only a 2 years one-off treatment, but obviously it's expensive. Obviously it has to be rationed, so you're going to use it in people with very low BMD, multiple fractures, and then perhaps those on steroids. Perhaps they've had new fractures despite receiving anti-resortives, and perhaps in a situation where a patient's had an atypical fracture or osteonecrosis of the jaw. And then lastly, strontium ranelate. Well, the good news is the fracture data are good and really good data in those over the age of 80. It's a different modality of treatment, so it's something useful to have available in the context of someone not being able to take or doing badly on bisphosphonates, or they've had an atypical fracture. We got 10 years data. It's probably good for osteoarthritis as well. There's an RCT for osteoarthritis. The bad news is it's awkward to take, GI side effects, DVT risk, that's a contraindication. And then we've got these new cardiovascular contraindications. So you can't give it to people with ischemic heart disease, strokes, etc. So unfortunately, it's pretty much sunk, particularly in the elderly. We've got some safety updates coming up soon from the MHRA. They might even pull the whole drug, which is a shame because it's been a useful thing to have available.